Thanks everyone for joining. We'll get started in just a minute or two. Okay, it looks like the attendees coming in has slowed down, so we'll go ahead and get started. Hi, everyone. Good afternoon. Thanks for joining us today. I'm Chrissy Giuliano, Executive Director of Big Cities Health Coalition. We're really excited to have such a strong and varied group of all y'all here on the webinar today. We have public health professionals, behavioral health leaders, social service providers, researchers, advocates. It's really a testament to how deeply we're all looking to find smarter, more compassionate, more effective ways to prevent overdose and promote health in all of our communities. At BCHC, let's go to the next slide, please. At BCHC, we work with leaders of 35 of the nation's largest metropolitan health departments. And on some issues like overdose prevention, work closely with a number of staff and health departments as well. These member health departments collectively serve more than 61 million people, or about 1 in 5 Americans. Our members, as I just said, like so many of you, are on the front lines of the overdose crisis every day. They've made clear to us that while we have the tools that work and we know what tools work, such as naloxone, fentanyl test strips, and in some places, overdose prevention centers, we need better public understanding and support for those tools so that we really can deploy them as needed. So that's what today is all about, digging into what voters in our member footprint really think about overdose, addiction, and the solutions we know can save lives, and how we can better communicate the work to the public and to policymakers so that these solutions resonate better with them and get more support. So this project is part of an ongoing effort at BCHC to keep developing our collective public health toolbox. On the screen are just two recent resources we've developed with partners to support overdose prevention work. The links are available in the slides, and we'll send those out after the webinar. Lastly, I want to take just a minute to thank our incredible partners and funders on this work. So first, a huge thank you to Dahlia Heller and the team at Vital Strategies, who provided the primary support for this project. This work would not exist without Dahlia's team and Vital Strategies partnership, and you'll hear from her shortly. We're also extremely grateful to our host of foundation funders for the broad support of BCHC in our communications and data work. All of that allows us to continue to advance local public health. So with that, I will turn it over to Dahlia from Vital Strategies, who will say a few words about their work to prevent overdose and promote health in communities across the country.
Thank you, Chrissy, and thank you to you and your team at Big Cities Health Coalition. It's a privilege to work with you all. I'm so pleased we're able to support this second round of message testing with BCHC and to update the findings from last year's work in this space. For those of you who don't know us, Vital Strategies is a global public health organization working on the prevention of injuries and non-communicable disease. I lead our work on overdose prevention, and here in the US, we're working intensively in a number of states and with some national-facing projects, such as this one. As part of the Bloomberg Overdose Prevention Initiative, we partner with communities and state and local governments to achieve an equitable and sustainable reduction in overdose deaths. The findings Big Cities Health Coalition is presenting today are invaluable for delving into the question of how we communicate about the issues associated with overdose and drug use in our cities. As Chrissy was saying, this playbook will help to unpack the perspectives of city residents on overdose, addiction, and drug use, and offer some messaging strategies to help build support for a public health response. We need this resource now more than ever, and I'm really grateful to have been able to support its development. And with that, I will turn things over to Big Cities Health Coalition's Communications Director, Elizabeth Green, walk us through the findings.
Great. Thank you so much, Chrissy and Dahlia. And hello, everyone. I'm so glad to be here with you today to share our newest work on how to talk about overdose prevention in a way that truly connects with the public and with policymakers. So today I'm going to give you some highlights from some research that we released a couple of weeks ago in our 2025 messaging playbook. And as Chrissy mentioned, even when city leaders and health departments are leading with clear evidence about what works to prevent overdose, they often find themselves getting caught up in some political headwinds and face criticism that these strategies, quote, encourage drug use or make neighborhoods less safe. So what we wanted to understand at the encouragement of our members was, what does the public actually think about these issues and what might persuade them to support a public health approach more? So to answer those questions, we partnered with Heart Research, which is a polling firm, to survey a little over 1,000 registered voters who live in BCHC cities, which you're again seeing on your screen. So they conducted that survey online in March of this year. And I should note that the sample was representative, the 1,004 people, that sample was representative for these cities across all kinds of demographics: race, gender, education, age, geography, political affiliation. But it is, of course, not nationally representative because cities just have a very different demographic makeup than the US as a whole. In the survey, we asked people to share their views on drug use, on addiction, on homelessness, on public safety, on public health. And I'll talk about why those issues are all kind of tied up together for us. And then we tested different messages to see which ones moved people from a relatively soft agreement to more strong endorsement for overdose prevention strategies. So, what did we learn? The good news is that support for a public health approach to overdose prevention remains broad, just as it was in 2024. So, by at least a 2-to-1 margin, city residents favor treating overdose and related issues as health issues rather than criminal ones. So let me tell you what you're looking at here on the screen. So we asked some very similar questions in our previous round of messaging research in 2024, and then again this year in 2025, and asked people, okay, given the choice between taking a more fix the underlying problems approach or public health strategies, we kind of described what that meant, versus getting tough, i.e. focusing on law enforcement strategies, which would you prefer? Do you think your city should prioritize one of these over the other? And we asked them that in general. We asked them with respect to overdose. We asked them with respect to crime and public safety. We asked about homelessness. And here on the screen are what they said with respect to homelessness and drug addiction and overdose. So you can see that particularly for homelessness, city residents are very much in favor, by actually a 4-to-1 margin, of using a fix the underlying problems, or what we might call a public health approach to these issues. And by a 2-to-1 margin, prefer that for drug addiction and overdoses. So there's already a pretty broad support for the idea that we can't arrest away these problems. Okay. Now remember, I'm sorry, I'm going to go back just one second. I got off script a little bit there, Walker. Remember that 67% number that you're seeing here, that rightmost green bar, because we're going to break that down a little further on the next slide. Okay, so that 67% is what you're seeing in the green. The dark green and the light green together are 67%. So we're going to break that down a little bit here. So we've seen the good news, and this is where we've got some more work to do, because when we look more closely at that 67%, we see that only half of those people, about a third of all city residents, definitely support public health strategies. So they're really on board. And then the other half of that 67%, about another third of city residents, say that their city probably should use a public health approach toward overdose. And what pollsters will tell you is that probablys have a tendency to change their mind pretty easily. So these supporters are not reliable supporters. And strategically, we should be focusing our efforts on shifting those people in that light green probably category into the dark green definitely category. Now, in this survey, this time around, we dug down a little deeper to see which specific public health tools had more or less support, and asked about, some specific, what we often call harm reduction tools in the field. And it may not surprise you to learn that naloxone had the strongest support. In fact, it's really the only one that got over a majority uh, of people feeling very comfortable with that particular strategy. If you widen it out to somewhat comfortable, all of these techniques, which I think is really interesting, even safer drug use equipment and overdose prevention centers, if we take very comfortable and somewhat comfortable together, had a majority in favor. It's just that those light green areas are pretty large and pretty squishy. And those are the folks that we need to focus on. Now, the fact that only naloxone broke through with strong support from a majority of respondents tells us two things. First of all, naloxone has become pretty well known. We've seen that it's pretty widely covered in the media. It's pretty easy to understand as a strategy, and it's pretty well accepted as a life-saving tool, which is honestly a huge step forward. And kudos to all of you for doing the work to get it there. But second, we still have a lot of work to do to build public understanding and enthusiasm for the other tools on this list. These strategies save lives too, and we need to help the public to see that. And this is where messaging matters. Most of the people that we surveyed weren't necessarily opposed to these tools. They just hadn't heard enough compelling reasons to fully embrace them, and sometimes didn't even know what they were. So we have a lot of people in this movable middle, as communications people often refer to them, folks who are generally on board with public health strategies, but who haven't been fully persuaded yet that our specific overdose prevention strategies are working. That's our opportunity and also our challenge. So how do we persuade people to move? That's where our message testing comes in. So, second big takeaway. Through the message testing portion of our survey, we found that city residents do broadly support the use of public health overdose prevention tools, especially where they see a clear connection to saving lives and providing drug users with a bridge to recovery. Now, we tested more than a dozen messages, and a couple of them really rose to the top as the strongest across most cities and subgroups within those cities. So let me walk through those couple that rose to the top and offer some insight into why they work. The first winning message is what we might call the complete strategy message. So let me read to you. This is the full script of what they would have seen and responded to. There are multiple causes behind the overdose crisis. So we need a complete strategy that includes short-term and long-term solutions. Cities that accept this reality are making real progress by embracing a complete strategy that includes saving lives in the short term with naloxone, fentanyl test strips, and overdose prevention centers, while in the long term, expanding mental health and substance use treatment options, increasing affordable housing, and creating more well-paying jobs. And if you're familiar with our messaging playbook from last year, you'll know that this is pulling straight out of what we learned from that messaging testing last year, that people want to see short-term and long-term solutions. They understand that it's going to take a while to really fix the foundations here, but they want to see some results right now. It needs to be all of it. The highlighted words and phrases are the ones that city residents really responded to as the best parts of each message. So, it's worth noting that those phrases are going to really resonate. This message works because it reframes overdose from being an individual choice issue to being a symptom of broader structural problems, things like housing instability, poverty, and lack of access to mental health care. And people in cities are generally pretty primed to get that approach. And this message, I think, also works well because it validates people's desire for both immediate and long-term action. They get that it's going to take a while to fix, but they want to see some results right now. And this message tested well pretty much across almost every group, except in California, which is a story for another day. But the next message did test well in California. So this is our second top performing message, what we might call the bridge to recovery. So it reads, not everyone will be ready for treatment to help them overcome an addiction, but we all know how much someone's circumstances can change in a month or a year, and by then they may be more willing to accept help. These actions give people the chance to get to that next day, that next month, or next year, so they can get help when they are ready to. Now, this message tested especially well with residents in California and in the South, and with Hispanic or Latinx respondents. And I think it appeals really to people's belief in redemption and hope, second chances, that sort of thing. People love that kind of story. And at the same time, it avoids that trap of assuming that everyone is ready for treatment today, which is an important precept of harm reduction. And we know that isn't always the case, that people aren't always ready for that right now, and perhaps might not ever be. So these are just two of the top performing messages from our research, and you'll find more in our messaging playbook online. And I just want to, in the next slide, just point out one other feature in the messaging that is really important. In that playbook, you're going to see that saving lives was a strong common theme that city residents repeatedly responded to positively. Saving lives is what you want to hit in your messaging every time when you're talking about overdose prevention. Now, the messages we tested talked at a pretty general level, but we were also curious to know what impact personal stories might have on people's attitudes toward overdose prevention. And one of our most important findings was that real people's stories move public opinion. And this, again, is perhaps not entirely surprising, but I think seeing the numbers is really striking. We'll get to the numbers in a moment. Our partners at Vital Strategies had just put together a couple of campaigns about overdose prevention and harm reduction. And so it was a good opportunity for us to use a couple of these short videos that feature individuals who were helped by overdose prevention strategies to kind of see what impact this has on people's acceptance of harm reduction and overdose prevention. So let's take a look at one of the videos that our survey takers watched. This is a 30-second PSA about a man named Terrell.
Well, harm reduction saved my life because of the chaotic lifestyle I was living, using drugs, coming to harm reduction where the arms were open. I was starting to feel like a human being, and they spoke to me and they used my name, Terrell. People that use drugs, they're somebody's father, somebody's mother, brother, sister, somebody out there loves them.
Now, I definitely encourage you to go and look at the other videos in that campaign, and certainly use them in your communities if you think they'll be effective. Stories like these really move people, and in our case, really shifted some people from that lighter green category, from the probably camp into the definitely camp. And we had heard loud and clear from city voters that they want policies that treat people who use drugs as human beings. And note Terrell mentions that. He really responded to being treated as a human being. And city voters really want to see the real world impacts of a public health approach to overdose prevention. They think it's really compelling and it's transformative to see these personal stories, especially for those voters who are kind of ambivalent about harm reduction as a strategy. In fact, more than any of our general messaging about our verbal messaging, these videos drove a lot of the positive movement toward support for overdose prevention actions. So let me break down the numbers for you here. So you remember this graph that we showed you a little earlier that broke down how people, we asked them at the beginning of the survey, do you think your city should support these kinds of strategies? And this was the breakdown definitely, probably, I have mixed feelings, probably, definitely not. If we just take that probably should group, at the end of the survey, everybody was broken out into halves, into a split sample, and half of the group saw the videos and half of the group did not. Everybody saw the messaging, right? All those verbal messages that I showed you earlier. But half the people saw the videos, half the people did not. And here's what happened. Of those people who said at the beginning, my city should probably support these things, probably. 25% of them, a full quarter of them, moved into the definitely camp just on the strength of the messages alone. But 45% of the ones who saw the videos moved into the definitely camp. So it almost doubled the number of people who shifted over into the definitely camp. So there's something about that combination of the argument and the personal story that kick of a personal just the kind of emotional support of that video. The two together really moved people into much stronger support. So if you're doing this work, tell your stories. Use video when you can, and above all, show the humanity of the people who are impacted by the work that you do. So to wrap up, here are the strategic takeaways. We have a great deal of broad support. You might not think so. It's really easy to focus on the negative, right? You see a bad comment on social media, you see a story in the local press that that is disheartening. I mean, there are all kinds of ways that it can be discouraging sometimes to do this work, but you've got more support than you realize. These videos, but that broad support could be a lot stronger, and that's where we have some work to do. We are facing a difficult moment right now, again, as you all know, as budgets are being cut, local votes are on the line, some narratives are turning hostile, and so we really need to strengthen up that support for the work that we do. Our communications goal then needs to be to solidify that support, to move people from soft agreement to strong endorsement. And we do that by emphasizing how overdose prevention saves lives, how it provides a bridge to recovery, and we tell real human stories of the positive impact that overdose prevention work does. Now, if you would like to dig deeper into the work that we've done, our full messaging playbook is available on our website, and we will share the URL to that playbook in the chat. I think Walker just shared it. It includes more of the message testing results, some regional and demographic breakdowns, and more strategic recommendations for those of you who are doing this advocacy work. Really appreciate your attention, and I hope this gave you some concrete takeaways and new ideas for how to use some of this in your own work, and I'll turn it over now for some questions. Oops. And I'll say while Walker's looking over some of the questions that, or while we're waiting for folks to kind of think through that, we will be sharing the slides for the presentation and the recording afterwards. We will send those out probably later this afternoon. So Shane, to answer your question, we don't have, I would have to speculate a little bit about why the responses were so different in California. In fact, I was asked the same question by one of our one of our members. And so I did go back into the data and look at this more carefully and think about, just given the context in California, why might the results be so different? And I think some of it is about the fact that the general landscape in California is very different, right? That people are very accustomed to public health approaches in that state, and it is much more just kind of an accepted part of everyday life, whereas in much of the rest of the US, that is not necessarily the case. And so, the movement is not going to be as strong. It is also the case that the visibility of drug use and overdose deaths is very high in California and has been for some time. And it has become a very hot political issue. And so a lot of the California residents responded much more to calls for immediate action. They wanted to see immediate results and were less concerned about the kind of responded less to the long-term goals kind of messaging. So I think there's a lot more to look into there, but yeah, it was really striking just how differently California's city voters responded to some of that messaging. Marie, where people asked why they responded the way they did. For example, why they, are kind of in the probably category versus the definitely category. No, not per se. We were trying to do a lot in this survey, and asking them why was not a luxury we had here. Although we did in the previous round of messaging research, which was very closely related. We did do some focus groups, and so we had some more opportunities to have kind of longer conversations with people about what was behind their responses. And a lot of times people, it was based on very personal experiences. A lot of folks, one of the things that was very striking to me in listening to some of the focus groups was how many people, for example, had personal or very close family and close friend experience with housing insecurity, with substance use, with overdose. And so, we're not perceiving this as an issue that's over there, but we're seeing it as an issue that is very much in their sphere. But that's just sort of one aspect of that. Totally different, Shane, in California. I live in a very rural part of California, and messaging that works in LA doesn't always resonate here. No way. Personal stories are powerful, but they have even greater impact when they come from someone within the community. Absolutely. I'm also wondering if there has been any research focused on rural communities. Yes, I know that there has been. It hasn't been done by us, it's in the name. But certainly there has been. And I don't know, Dahlia, do you have any insight as to, what kind of research has been done?
No, I don't know of any actual specific research on messaging around drug use and overdose and addiction in rural communities. It's a good question. I don't know of anything.
Yeah, it is a totally different context. And I think my suspicion, Shane, is that, one of the things that I didn't really talk about this in the presentation, but one of the things that you're contending with when you're trying to do public health in the United States is that people think about health as as being under individuals' control, right? And particularly drug use is seen as a matter of individual choice more than a matter of public health. In other words, people see drugs as something that you can pick up or put down, and it's your responsibility to do that. And they don't think about the structural issues that sort of affect that an individual's relationship with substance use. My suspicion is that that is even stronger in rural areas than it is in cities. You see about a half and half relationship in cities where when you ask people in our survey, do you see this as more of a health issue or an individual issue? It's about half and half. And I would guess, and I really am just guessing, that the proportion of people who see it as an individual choice issue is even higher in rural areas. And so you're going to want to think about um, how to capture a sense of community that rural people will really respond to, how to kind of engage the rural community in a way that about a sense of community responsibility um, for the people that they love and the people that they care about, in order to engage with those public health concepts. Any challenges or specific successes shared about harm reduction vending machines? Yeah, so those actually got a pretty good response, in terms, like when we asked about specific tools, in the toolbox. Um, we actually referred to them as harm reduction, or what do we call them? I remember we called them kiosks. I'm forgetting what the actual, oh, here we go. Thank you. Harm reduction kiosks. The polling firm that we worked with was worried that vending machines made it sound too much like it was dispensing candy and soda, and that it would just make people freak out about what are we doing? Like we're just dispensing uh, drug paraphernalia like candy and soda. So we said kiosks instead, just to kind of avoid that association. It got a pretty good response, as you can see on the screen. I think my suspicion is that the lukewarmness of the response has to do more with people just not really knowing a lot about them rather than having a lot of direct opposition to them. But I don't know. We didn't really have the time to sort of delve into that specifically. Um, but I have noticed that every time that there has been a new harm reduction vending machine introduced in any of our cities, that at least the media coverage has been very positive. So I'm not sure what your experience has been, but it seems like that one is a pretty it's not the hardest sell, let's put it that way. Oh, thank you. Jennifer Bender recommends, she says it's about rural Appalachia, not California, but perhaps look at healthinappalachia.org. Thank you for that recommendation, Jennifer. I really appreciate it.
I just wanted to jump in on the opioid settlement question. So I dropped a resource in the chat that we at BCHC and our partners at Prevention Institute have worked on with funding from CDC. And the question about the opioid settlement was, how can we work to get opioids funds to the people that have been negatively impacted directly and indirectly, instead of being tied up in states, government, etc. So one of the goals of this work that, again, we've done with some partners is to make sure that a public health approach works into how opioid settlement dollars are distributed, engaging community, focusing on prevention and things like that. So I would, like I said, sort of share that. And then, I think I would say to all of you sitting in communities across the country, engage with whomever is in charge of the opioid settlement dollars in your jurisdiction. And that's going to obviously depend a lot on where you're sitting and where that decision-making body is. And Dahlia also just dropped in the chat some resources. Vital Strategies does some work on this as well. Dahlia, I don't know if you have anything to add.
Sure. Just to add what those are designed to be a sort of state by state guide for what's happening with opioid settlements planning in your state and how to engage. So it's really about the entry point for community into these conversations, to the point of the question I think that was asked earlier. Just wanted to share that resource.
Such great questions. I just realized I skipped one up here. Have you tested any messaging specific to stigma prevention and reduction? Not that specifically. I'm trying to think how to answer that question. Actually, one of the I will see if I can grab the URL for this, but the deputy substance use director in San Francisco, Jeff Hom, just did an interesting study on this that looked at how people respond to different kinds of photographs of people who use drugs, and photographs that we might consider to be more stigmatizing and those that are considered to be more, that they found more humanizing. And there were some really interesting findings from that, including that one of the things that was really striking to me was that it's been a while since I've read this, so let me make sure I'm getting this right. That there was not that the amount of stigma that people attached, the people did not respond any more negatively or with any they did not respond any more negatively to stigmatizing photos of people of color than they did to stigmatizing photos of people who were white, which I thought was really interesting. And that destigmatizing photographs really didn't do much to persuade people to support harm reduction strategies. It really just made people want people to get into treatment and recovery. But the sort of prevention, harm reduction aspect of it was not really aided by focusing on destigmatization, which seems really counterintuitive to me. And I think there needs to be a lot more work to figure out what's going on there.
I dropped the link. It's a blog post that Jeff did about but it also links to his research in there as well. So yeah.
Thank you. Becky asks, how applicable do you think this data is to broader population of the US or whole states? That's a great question, Becky. I think it's a good jumping off point for those of you who are not working in the large cities in our footprint. I think it at least, gives you some food for thought, and you can compare when you see this sort of larger discussion of what we found in our research. You can probably do some comparison to how you see the attitudes in your own community and figure out how much does this really pertain to my community or not. I think, for example, best how much your community is concerned about community safety. Like what are the driving concerns in your community, and how can you attach the benefits of the work that you do to that, right? Like if the concern is about jobs and about more affordable housing, then connect it to that. You've got to think about, what are the real concerns in your community, and how is the work that you do helping to solve that, helping to get people there? That's probably the best way to think about the applicability, is just to kind of think about the recommendations on a kind of broad level, and then think about the needs of your community and how you can connect your work to that. Can you talk about how to or not discuss the role of structural racism in overdoses? Yeah, and this is a really obviously a really tricky thing to do right now, right? Because it absolutely needs to be done, and also in the current political climate, it's just been made into uh, a difficult conversation to have, which is ridiculous. Like, why we have to have this conversation? Overdose is, is affecting different communities differently, and a lot of that is rooted in structural racism. Full stop. Like, that is just a fact. So how do you talk about that in a way that's actually going to land rather than shutting people down? It really depends on who you're talking to. So, if you are in a community that really shuts down as soon as the word racism comes up, then you're going to have to come at this from a slightly different direction, right? And talk about, and what I've seen a number of people talking about, um, we need public health always serves the communities that we look at the data, we see which communities need this support the most, and we go there and we work with, we support those people. We follow the data. You sort of find ways to talk about the need for addressing structural racism in a way that isn't going to just immediately fall on deaf ears. But if you have a community that can talk about this, then absolutely, you've got all kinds of open doors here in this research to get there, right? Like, people are clearly ready to talk about affordable housing. Well, there's an open door to talk about, we have a city with a long history of shutting people of color out of, owning homes and out of living in certain communities. And that has created a situation where, you can tell this whole story in a way that doesn't just land it in a phrase, but actually walks people through the whole history so that they understand why racism has anything to do with overdose prevention, because they don't necessarily understand it. That was a very long-winded answer, but this is a big question. Is there anything else either of you would want to add to that, or?
I mean, I think, to the point, just to put a finer point on it, you can't answer that everywhere, right? And so, also, just as Elizabeth said, going back to the data that show that there are differences in overdose rates, and much of the decreases we've seen in overdose deaths is not among people of color. That was terrible grammar. But I think, again, where you don't have time or openness to the whole historical story, and I'm not dismissing it, I'm just being pragmatic. We have real data and real numbers to show that there are differences, and we need to address those. And sometimes that's what you need to tack to, and you're still, trying to move the needle forward on, keeping people healthy. But you just can't always give the whole long, full background answer.
And I would just add, you're still talking about access to resources, and that's a way to center the conversation on how do we respond. So to Chrissy's point, we see the disparities, they're there in the data, and not just disparities, they're disparities that emerged so that deaths continued to go up and skyrocketed, not just the disparity grew as deaths went down in white populations, but deaths have gone up as well in Black and Indigenous populations especially. And so speaking then to the issue of access to resources as being key to any of this, all of those overdose prevention strategies are what we're trying to get to. So I think that's a context for speaking to structural racism without having to use big words like that may lose your audience to.
Right. Yeah, and actually, while we're talking about, I think there are a lot of shorthand terms that we use in the field that are probably best to avoid um, when you're having conversations with people outside the field, and harm reduction is probably one of them. You notice that in much of this presentation, I talked about overdose prevention rather than harm reduction, and that is because the you notice I also said that saving lives is what people really respond to. Preventing overdose, that's what people want to see, right? Reducing harm, it may be a totally accurate description of what you're doing, right? But that's not what people care about. They want to see particularly fatal overdose stopped, but non-fatal too. And so the more we can, and also they don't even know what harm reduction is, like reducing harm from what. Um, so the more kind of plain language you can use that really describes in vivid, understandable detail what you're talking about, the better off we are. Um, Keith asks, can you please speak more about the mixed feelings groups? Can any of them be nudged toward probably or definitely? Oh, we've got an overachiever on our hands. Um, that is a good question. Honestly, I haven't looked very closely at the mixed feelings group because there was plenty to dig into with the probably group. Um, so I actually can't answer that question without just sort of making stuff up. But yeah, I'd have to go back and sort of look at the data to give you any good insight into them. Sorry. Shannon, tips for how to keep momentum going with national data pointing to a decrease in fatal opioid overdoses. We presented some updated local data recently and had some pushback that we don't know enough to attribute harm reduction strategies to this decrease. Yeah, that's such an interesting question, and I'm sure an experience that a number of people have had. And then the issue is, right, that, we've seen nationally and in, a lot of communities and states across the country that the fatal overdose rate is coming down. And so, the what we would like to be able to say is, look, the work that we're doing is paying off, but actually drawing the causal line from the work that you're doing, it's not just a correlation, it's a cause. Like the thing we are doing is actually making this happen. That is much, much harder to do. And I am not qualified to answer that question of how you sort of show that that is the case. Do either of you have some suggestions for like making that strong causal connection?
I will just throw in there. I think this idea that we have a causal connection for many things that happen in our communities or in our societies for that matter, that there is a very clear if A, then B, is probably false. We live in a complex ecology. And I think like if you think about the question in an ecological kind of way and think about, well, what has the ecosystem been like of overdose prevention response? What services have you been focusing on standing up? What services have been expanding? What access to resources have shifted, changed, grown? What new places have started to receive services? What new credible messengers have been engaged in sharing that information? I think probably your jurisdiction has been expanding that work and developing that work steadily over several years now, as we've had funding to be able to do that, have had kind of a supportive environment to be able to move some of that work forward. Whether it's not supportive locally, there's a broader kind of, has been a national discourse that has moved us towards a more of a public health framework in talking about drug use and overdose prevention. And so I would say that you can point to that you're not trying to lay claim to a causal relationship necessarily, but that the ecosystem is the most important thing because, I mean, you go to some old, one of the old kind of, phrases of no wrong door, or, that it should be easy for people to access resources that are going to prevent overdoses in their lives and their communities, and that is probably the work that you've been doing. So you can point to that. You're not claiming everything, but you're stating what's the work that's happening, and that's what's happening in the data. So I think it's strong ground to stand on.
And I think likewise, as we see an environment shifting and resources going away, telling the flip side of that story of what various folks and communities are no longer able to do. And there is a possibility we see in, a new year's worth of data, an increase in overdose. Is that causal? No. But can you make this? I mean, maybe was my point. We don't know. But you can make the same point. And, one of the things that we've been trying to do is tell the story of impacts of policy and funding change. And I think this is a place where we're also going to see it. There will, in most places, objectively speaking, probably be less resources for all of this work.
Yeah, and maybe some analogies can help here too. I mean, I know that, seatbelts have been a helpful analogy for a lot of harm reduction work. And, we don't know, even in an individual accident, if a seatbelt saved someone's life. There are all kinds of factors that go into someone surviving an accident or not. But we do know from many years of data that once we, started requiring people to wear seatbelts, the numbers of people who died in accidents started dropping precipitously. So, so there's a good analogy to be drawn there. And I think, naloxone is probably a good thing to point to. In fact, I know, I'm forgetting which jurisdiction does this, but I think it might be Detroit. They put, I think what they do is they put QR code stickers on all of their naloxone boxes that they distribute, and then ask people, like, when they leave them at businesses or, hospitals or schools or wherever, if you use this, scan this QR code. And of course, a lot of people aren't going to do that, but some people do. And then you get some data about, okay, this was used. We distributed this naloxone, and we know this many were used. And because, naloxone has such a clear, like, the person has overdosed, the reversal drug was administered, and we know from testing that this many times out of 10 that saves the person's life. Like, that's real causal data that you can show.
And there are a number of different organizations trying to improve some of those data points that do get closer to causal. One of them is CDC Foundation, who has a project on different sort of opioids related metrics. So, there are other different, hopefully better ways to capture some of this. It's just evolving over time.
See, I think we've got time for these questions. Are great. Thank you all so much for your thoughtful questions. So Charlie asks, have you all seen any successfully implemented programs focusing on Black and Brown communities to help address the increase in opioid overdose and death rates among those populations? Dahlia, I think you all have a program that's working on this very issue.
Programmatically, I think we've done a lot of different work. Vital's working in a number of states. Maybe some of the folks on this call are from some of those states, but I think and everywhere we're working, we kind of hold equity at the center of all of our work. So certainly, like attending to racial equity and how we think about what we're trying to do and what we're trying to address has been central to our work. So, but I'll give some examples that I think are pretty, I would say, straightforward, but actually quite effective, right? Which is like partnering with community leaders in Black and brown communities in the places where you work. So, and then sitting down with those folks and asking, how do we get these resources? Who do you reach in your community? What are these kinds of resources? How would these resources land in your community? How would you see best getting them into your community? And then providing resources and support to those community leaders and their organizations and their groups to provide reach and access locally. I think that's key, right? This is about community partnerships. And I think, like, especially in health and in public health, it's a story that we've been through many times. I feel like recently I've had this conversation with folks a number of times, like we went through this with COVID, right? Again, how do you reach communities, and how do we reach Black and brown communities who are at much greater risk, and who are the messengers, and who are the organizations who are trusted, and what are the settings, and you know, and then what is the messaging? So that's a really important, and it's an old HIV story as well. I mean, we've been through this ground, I think, for a long time in public health. So it's the same. Yeah, and then I think, like, you know, you're mentioning also, I mean, we did recently have put together a campaign to focus on increasing awareness and access to naloxone in Black communities in a number of cities in the states where we're working, and found that that campaign was really effective. We'll be doing a webinar about that campaign in about a month to share the findings from our research, and we would welcome, and I think we did a webinar with big cities recently, we would welcome other cities to join the campaign. We have a campaign website, which the campaign just drives people to the website, and then the website people can go and find out if, you know, if you live in this city, click here where to get naloxone. But what we found was really important. We did a lot of message testing early on to get to the what's an effective campaign going to look like, what does the messaging need to be, and who are the messengers. And we landed on community leaders as the messengers. And we mean that sort of broadly, like, you know, could be informally in my community. This is a person who's a go-to who always knows what's going on or where I can get the latest whatever information, access to resources. So that was key. We featured community leaders, and the sort of idea of featuring community leaders, or community leaders being spokespeople and being sort of, you know, resources in the community. And then it was really about providing, it's called "You Have the Power to Save Lives" was the tagline. And it was really putting the power into people's hands and saying, this is something you can do. And holding naloxone, we heard this a lot at the beginning, of like, show somebody, don't just show naloxone and show a human being, show somebody holding the thing so it feels accessible. It's something you can have, you can hold, you can carry. And it was about, how do we talk about drug use in our communities, and that this is happening in our communities. And I think it was, what was really telling for us was recognizing that this messaging, where we've done a lot of naloxone work, I think across the country, everybody has done a lot of work to get naloxone out and awareness and into people's hands. But it's not reaching everyone because of how it's being communicated, and who are the communicators, and where it's being made available in what kinds of ways. So for folks, for people to have to show up and say, like, I need this, and where are you asking people to report for? So lots of things to consider. Yeah, I'm talking a lot, and I think we're reaching the end of your time. So, but yeah, thanks for the question.
I'm sorry we didn't get a chance to answer everyone's question, but really appreciate you all's time and attention today. And thank you, Chrissy and Dahlia, for joining us. And we will look forward to seeing you in the next webinar. Take care, everyone.